All right, let's make a start. So yeah, thanks everyone for joining this evening. I'm David Thwaites from Complete Sports Care, and yeah, welcome to this Rotator Cuff webinar this evening. So again, we've got a great lineup of speakers. So both don't really need a huge amount of introduction, but I will introduce you anyway. Firstly, we have Associate Professor Peter Malliaras. So Pete is a physiotherapist and researcher in tendinopathy based at the university, based at Monash University in Melbourne. And he works clinically at Complete Sports Care in Hawthorn. So Pete's presentation tonight will be on game-changing trials for rotator cuff tendinopathy. So thanks for joining us, Pete. And secondly, tonight we also have Mr. Austin Vo. So Austin is a world-class orthopaedic surgeon specialising in minimally invasive shoulder and knee surgery. So he has a strong interest in research and training for future surgeons. So Austin consults in East Melbourne, Werribee, Box Hill and Mornington. And Austin's presentation tonight will be on the latest management techniques for rotator cuff. So thanks for joining us, Austin. We've also got Steph Gord. So Steph's going to help us out with the Q&A function this evening. So just to let everyone know about the Q&A function. So this is how we'll be running our question and answer forum at the end. So yeah, please fill up with as many questions as you can think of, and we'll pose it to the two experts at the end. And Steph and I may answer a few as we go in real time as well. But yeah, we'll try to pose as many to the two at the end. So without any further ado, let's get started. I'll hand over to Pete.
Thank you very much, Dave. Thank you very much. I'll just share my screen and get the slides going there. Can everyone see the slides there? Okay, hopefully you can see them. All right, well, look, thank you very much. And thank you to Dave for the invite, I guess, to come and talk today. Thank you very much to Austin. I'm really looking forward to Austin's talk and a surgical perspective as well after this one. I'm going to talk today on, I'm going to be talking about, I changed the title for the presentation, basically, just to keep Dave on his toes in the lead up in the few minutes just before we started, to recent game-changing trials. I thought that sounded a bit better than the original one, because we've been really lucky with rotator cuff. There's been lots and lots and lots of trials recently. I've been interested in tendons for probably the best part of 20 years now, from doing my PhD through to sort of postdoc work, but mainly lower limb. In the last probably 6 years, I've also become very, very interested in rotator cuff, just from purely a sort of interest point of view and academic point of view, but I'm also starting to see more tendon shoulder patients in the clinic. And Steph is also here tonight and seeing a lot of shoulder patients with me. We'll talk about a little bit about a class that we're running together as well. So that's exciting to sort of start doing more of the shoulder work. So basically, I do work at Monash University. I work at Complete Sports Care here as well, 1 day a week, and running the Monash Musculoskeletal Research Unit. And the focus there is primarily on Achilles as well as shoulder tendon research. So the questions that I thought I'd cover today very briefly are looking at what is the evidence for exercise interventions for rotator cuffs. We'll focus a bit on evidence to start with. Is there an effect? Is there an effective exercise dose? That's an interesting question, and there have been recent trials that are sort of trying to address that. New trials that have informed practice. So there's also some really good pragmatic trials that have come out. So I wanted to touch on those pragmatic trials. And then I wanted to then finish off with talking about the sort of intervention that we've developed. We've developed a new intervention for shoulder pain, which I say it's a new intervention. It really does build on all the excellent interventions, a lot of excellent interventions that are already out there, which I'm going to talk about. And it's just really an adaptation of some of those. So Yeah, so that's pretty much what I'll talk about. So just as a reminder, we know rotator cuff tendinopathy is a condition that affects the rotator cuff tendons. It can also impact on the bursa. Most of the shoulder pain that you will see in a clinical setting is probably related to rotator cuff tendinopathy. So about 70% of shoulder pain presentations that we see in a clinical setting will be related to rotator cuff tendinopathy. So it is by far the most common type of shoulder pain, but it is, quite a broad banner sort of, I guess, term, and you've got under it, or I guess you could say next to it, things like rotator cuff disease, subacromial pain. So subacromial impingement, it's a term that is sort of, the literature is telling us now, don't use subacromial impingement. And the reason for that is people start to think that they need surgery because they've got something impinging that needs to be removed. So there's a sort of consensus that we should probably move away from that term. Rotator cuff tendinitis, tendinosis, so issues specifically with the tendon, subacromial bursitis, rotator cuff tear. So all these things can happen as sort of pathology or sort of, I guess, mechanisms within the sort of underlying rotator cuff tendinopathy that I'm going to spend most of my time talking about. So we know that generally it's a clinical diagnosis. So people will most commonly have pain when they're raising their arm. They'll have pain with movement, particularly overhead movements, but they don't tend to have any restrictions in their range of motion, like say frozen shoulder, or will it be stiffness as well. So they might have restrictions in movement, but mainly related to pain. Usually it's a gradual onset. So as opposed to your sort of traumatic type issues where you might be thinking maybe you do want to get imaging. Most of the time for rotator cuff tendinopathy, imaging is not necessary to make a diagnosis. You can diagnose it on clinical grounds. What we use generally for diagnosis is the BEST criteria. So the BEST criteria from the British Elbow and Shoulder Society. And they've come up with some really simple and I think really useful criteria for differentially diagnosing rotator cuff type disorders from things like neck pain and things like AC joint pathology. So certainly in the trials that we're running on shoulder pain at the moment, rotator cuff tendinopathy, we tend to use the BEST criteria to try and diagnose and try and clinically diagnose without the need for imaging rotator cuff tendinopathy. We know that, just a quick review of risk factors, we know that people generally develop rotator cuff tendinopathy gradually. So they'll develop it usually from a change in activity. So there's been some sort of change in activity. They'll start to develop shoulder pain. So these predisposing factors, but really the key thing is looking for a change in activity. Most people present with some sort of change in activity, overhead activity. Usually you see rotator cuff type symptoms in people that do lots of overhead activity, whether that be work related or sport related. So often activity is a key factor. And we know that for tendons in general, you tend to get a change in the tissue. So the tissue will start to become pathological, and this can happen way before you get any change in, or you get any symptoms of pain. So you tend to get change in tissue that precedes the onset of pain. But we also know we need to look for other factors, and we treat rotator cuff tendinopathy as a biopsychosocial disorder, just like with any other persistent pain disorder. But there are systemic factors that can also be contributing factors. So things like elevated cholesterol, people that are less active and deconditioned, long-term steroid use, diabetes, older age, and many other risk factors as well. So these are things to consider. Now, I think Austin will probably talk about this in a lot more detail than me in terms of surgical approach for specific types of presentations and sort of tendon issues that you see. But generally for rotator cuff tendinopathy, we're talking about pathology in the tendon, in the rotator cuff tendons, primarily supraspinatus, but also potentially bursa thickening and bursa changes as well. So that sort of comes under the banner of rotator cuff tendinopathy as well, or rotator cuff disease. One of the interesting things is that there's not a close relationship between the pathology that we see on imaging and pain. And there are lots of studies, mainly cohort studies, where they look at large groups of people, and they look at people, say within a certain sort of town or village, and they'll sample as many people as possible. And what they look for is people that do have shoulder pain and people that don't have shoulder pain. And then they also look at the pathology underlying or related to, I should say, whether they have pain or not. And what they find is that, yes, you do get pathology in people that have shoulder symptoms and shoulder pain, but you also get a pretty large proportion of people who have shoulder pathology but don't have any pain whatsoever. So we know that pathology per se is not necessarily going to be painful, and maybe not necessarily also something that we need to target with treatment and with management. And certainly the approach from a sort of clinical practice guideline is that the first line treatment should be non-surgical and should be focused on education, exercise, should be focused on therapies that really are not specific to pathology. So regardless of what pathology is underlying that clinical diagnosis of rotator cuff tendinopathy, the initial management that we do is not really sensitive to that specific tissue pathology. It's a broad management that we try and see if people are going to improve with non-invasive type treatments before we then refer to people like Austin and start to think about more invasive, more I guess you could say tissue specific type treatments. And this evidence, this cohort study evidence, is really, really important in really sort of reinforcing that. So that was a bit of a review of, I guess, pain and pathology, and also diagnosis, just setting the scene in terms of rotator cuff tendinopathy. What I want to move on to now is some of those questions that we talked about. So my interest in rotator cuff tendinopathy probably, I think, largely started from this systematic review by Rochelle Buckbinder's group. And in this systematic review, it was really interesting. It's a Cochrane review. And when I first read this, I think it was in 2014 or 15, I didn't read all 346 pages of the PDF document, by the way. But Cochrane reviews are really good because they're obviously the highest level of review possible, but they also tend to be quite blunt. And what I mean by that is they don't look at the nuances of, say, for example, exercise and whether exercise is delivered in a way that we think is probably going to lead to benefit or not. So they don't look at nuances like that. And I think those nuances are very important. So this Cochrane review included 60 trials on exercise, and only 3 were at low risk of bias. So not many. And there were the main bottom line message from the Cochrane review was that exercise combined with manual therapy may not be different to placebo. And so that message is really important when it's in something like a Cochrane review, because many people look at Cochrane reviews as the source of evidence. So I thought that's interesting when you think that exercise is really the main thing that we do for rotator cuff tendinopathy. So there seems to be a real sort of disparity there. So we were sort of, I was interested in looking at this a little bit further. So I started getting interested in the dose and thinking about whether there are specific doses that maybe with some exercise, and I guess it's the premise that not all exercise is equal. Some exercise might be better than others depending on how it's delivered. So thinking about dose and seeing if we can see some relationships. So when you're thinking about dose, generally the parameters that people talk about are frequency. So how many times a week, for example, you do it, the volume, and that's given by sort of things like sets and repetitions, or the contraction type if you're doing isometric exercise, or things like intensity. So the intensity of loading on a RM scale or something similar. And there's many ways you can look at it. So here's a summary of some of the ways you can look at. I mean, if we take volume and intensity as the key variables, you can look at lower volume and lower intensity compared to higher. You can look at just lower intensity, lower volume, but equalized intensity. You can look at lower intensity, but equalized volume. And you can look at equalizing what they call work. So work is the integral of volume and intensity. It's when you basically multiply those things together. So there are sort of arguments also to look at equalizing work, and a lot of sports science literature does this because they want to know, if you do equalize work, what's the key factor? Is it volume or intensity? So there are many ways of looking at the dose question, and there's no right or wrong really. It does depend on the research question and what specifically you're interested in. So taking that interest a little bit further, the next thing that we did was we undertook a couple of systematic reviews to try and delve into these studies a bit more. So we specifically looked at studies within the Cochrane review of 2015. So we mined all the data from that review, all the studies, and we basically took the studies and we said, okay, if we look at them differently, if we look at them in terms of dose, is there a difference? Is there, can we see that there is differential effects? So the first review was looking at higher versus lower dose exercise in rotator cuff tendinopathy. Rochelle Buckbinder, who is also an academic at Monash University, I invited her on the team, and she, I'm very happy that she agreed to be part of the team because she was in that initial review team that did the Cochrane review. So we set out to try and answer that question. Now, just a caveat, the evidence that I'm going to present to you is low quality, low certainty evidence. So, and there wasn't many studies that we found that actually addressed that question specifically. There was only 3 studies within those 60 in the Cochrane review that actually looked specifically at higher versus lower dose for rotator cuff tendinopathy. And these were the studies, and this is a summary. I'm not going to go through this in detail, but I'm happy to share the slides after. Basically, there was one study that looked at lower volume. The comparator was lower volume and no load, whereas the intervention was higher volume and loaded. There was then another study that had lower volume of the comparator, but both groups were loaded. So the difference was higher load only higher volume only in the intervention group. And then the other study, the third study, looked at the same volume. So they equalized the volume, but the intervention group was loaded. Okay, so there was 3 different ways that they looked at the dose relationship, which made it hard for us because we couldn't really pull anything in meta-analysis. Okay, but we did find some evidence for increased load, increased volume having some beneficial effects. We also found that it was clinically meaningful when you look at the outcome of function, but it wasn't clinically meaningful when you look at the outcome of pain, which I think is interesting, and we'll talk about more in a second. Okay, so there are some preliminary data, I guess you could say, very low certainty data that suggests that maybe there is an effective exercise dose for rotator cuff tendinopathy. The next review that we did looked at a slightly different question. So this was the effectiveness of progressive and resisted. This is a bit of a mouthful. The effectiveness of progressive and resisted and non-progressive or non-resisted exercise in rotator cuff related shoulder pain, which is the same as rotator cuff tendinopathy, so don't panic. And so in this study, we had 7 trials that we recruited and we identified, and 4 of them looked at progressive and resisted exercise versus placebo or control, and the other 3 looked at non-progressive and non-resisted versus placebo or control. And we just wanted to know, is there differences? And there was. So if you look at progressive and resisted, there were benefits compared to control that were clinically important, again, for function outcome, but not for pain outcome. And then if you look at the non-resisted and non-progressive, I'm going through this very, very quickly. And again, I'm happy to share the slides, but this is, I should say, this is a forest plot. And the diamond recommends the pooled effect, represents the pooled effect of all these 4 studies here. Okay, so there's this, and this is favoring the exercise group, the progressive and resisted exercise group as compared to the control group. So clinically important difference for function. When we looked at non-progressive and non-resisted exercise, there were no significant difference, let alone clinically important difference when you compare it to control or placebo. So there were differences, again, we found in this second review, again, suggesting that potentially the way you implement the exercise or the type of exercise you do possibly makes a difference to particularly function outcomes, so self-reported function outcome. And this, I just wanted to flag this just to go full circle with the, I wanted to go full circle with the Cochrane review. So in that Cochrane review, a large part of the conclusion was based on this study, which is by Kim Burnell, and it's a great study. Kim Burnell is a really, really top-notch researcher. The study is good, the science is good, the quality is good, but the intervention was not progressive and resisted. A large part of the Cochrane review conclusion was based on this study that was not progressive and resistant. So I just wanted to highlight that sometimes you might have a very high quality study, but the intervention may not be what we perceive to be possibly the best intervention for delivering benefit. So one of the interesting things that we started thinking about from the systematic reviews that we've done in this area is what's the mechanisms for higher dose exercise. So one of the simplistic views is a bio view. We're thinking again about our biopsychosocial model, and the bio view is that you improve strength and magically pain gets better, function gets better. But we know that there's no real good rationale for why pain should get better if you get stronger. There's no real, I don't think anyone's come up with a really good rationale of how pain improves with high dose exercise or any exercise. So what probably mediates the effect is all the psychofactors like improved self-efficacy, improved confidence, reduced pain-related fear. So this is sort of something that we're starting to think about now with cohort studies. And there's a lot of work in this area already, especially in back pain, but probably less so in tendinopathy. One of the I guess disappointing things of the literature is that the trials that are out there for rotator cuff tendinopathy don't report the interventions very well. So it's very hard to get a very full impression, a very good impression of exactly what people have done. This is a study by, again, Rochelle Buckbinder's group, where they looked at how well reported exercise interventions for rotator cuff tendinopathy were in the literature, and they published that in 2019. And they used the CERT, which is a consensus of exercise reporting template, and it has 16 criteria by which you can rate how well reported interventions are. And they found generally it was, not very well reported, especially when you look at some of these progression. Well, I guess most variables were well reported, but some of the ones we're interested in and we've been talking about today, like exercise dose, it generally is not very well reported. So you don't get a good idea of exactly how they've done it. And that was part of the reason why we only were able to include 3 studies in the first review I talked about, because we had to exclude studies because they didn't make it clear exactly what they did, which was disappointing. Another one, this is one of my PhD students' unpublished work. He's about to submit this scoping review, and I think he's included, I think it's 200 studies looking at adherence in the musculoskeletal literature. And one of the problems with trying to understand if dose impacts outcomes is that we don't really know, unless you supervise people, unless you watch them, what they've done. And that's because a lot of the data for adherence is self-reported. So we don't really have a good idea and a robust idea. And in this study, where he did include over 200 studies looking at adherence in the musculoskeletal literature, he found that 91% report basically self-report frequency, and that's all they do. So you don't get any idea of volume, intensity. So you really don't know what they've done, even though you've prescribed something. What they've actually done could be vastly different to that. So that's something to consider when you're sort of interpreting these trials. This is a more recent trial from the group in Denmark, and I wanted to just bring this up because this is sort of starting to address some of the limitations in the literature. So this is the SEXY trial, and in this trial it was a pragmatic trial. So with pragmatic trials, you're generally looking at trying to undertake trials in the environment where the patients that are going to ultimately benefit are, rather than a more of a contrived research environment. You tend to have longer outcomes. You tend not to be so concerned about adherence, because you want to know, partly, will this population actually do the trial? So the question in pragmatic trials is, will this work in the intended population, as opposed to efficacy trials where you're asking, will this intervention actually work in the best possible conditions? So this is a pragmatic trial. A lot of the earlier ones that we've talked about are more efficacy trials. So when these guys set out to increase the dose of exercise for people who already are receiving in clinical care exercise within the public health system in Denmark. So they basically did a really, I think, smart design where they basically just randomized people that already went to the physio in Denmark for the shoulder pain to either get extra large dose of exercise or not to get it. So they were looking, is an additional dose of exercise going to be beneficial for these people? That was the key question. And one of the really good things about this trial is that they reported all of their intervention in full. So they have this really nice table, and it shows pretty much everything that you need to judge the intervention in terms of how intense it is and the parameters. So this is I think really something that we really need to do when we're, as researchers, to be able to have an idea of exactly what was prescribed. So they had 3 phases of the exercise, and you can see it's progressive. They progressed to an 8 RM intensity from a 20 RM intensity. And I just give all the extra details there. They sent them out TheraBand, and they just sent them out, exactly the additional exercises they should be doing. The other good thing about this trial is that they also looked at measuring adherence. So they used this thing called the band sizer, which is actually developed in Denmark, and it's this thing here. And what you do with it is you put it on a TheraBand. It just connects to the TheraBand, and it actually measures the amount of, it measures strain in the TheraBand, and it gives you a measure of time under tension. So theoretically, or hopefully, I guess you could say, that patient is using that TheraBand for all the exercise, or at least putting the device on whatever TheraBand they use. And if they do that, you can then get a measure of time under tension throughout that exercise program, which is really useful. So what they found is that people who were in this group, in the extra group, did an additional 2.6 hours over 4 months. Which is not much, and that's one of the limitations of the trial. What they found out is that in this environment, people were not really up for doing a lot more exercise. they didn't really follow the instructions. I think they prescribed 16 hours over 4 months, and the people on average did 2.6 hours. So you can see they fell, really, really short. But at least they had that measure. And I think if you look at most of the trials in the literature, the adherence is reported to be 80%, and that's an average. 70–80% is usually what you find, but that's self-report, and we know that's really overinflated. So I think this is at least accurate, and it does help to explain the null findings. So they didn't find a difference between the two groups. There was no significant differences in most outcomes. When you're measuring adherence in a robust way like they did, it can really be helpful, because it basically tells us that the intervention didn't work, possibly because they didn't do it. So we at least have an explanation. So if you want to repeat this trial, you have to have strategies to try and ensure that people actually will do the intervention if you're still thinking that that's going to work. Just wanted to touch on a PhD student's trial. So this is Josh Norton's trial, and what Josh is doing is he's actually undertaking a pilot and feasibility trial, which he's doing right now. He's midway through recruitment, and he is looking at a high dose. He's looking at a very high dose intervention versus a lower dose intervention, which I guess you could say is pretty much like a control intervention, very low dose, very low volume. And he's comparing that to, well, I think the volume's equalized, but he's certainly got a higher dose in his intervention arm. And that's off the back of the systematic reviews that we've done, trying to then understand whether there is an effect, and hopefully we'll then go on to a full-scale trial where we can investigate this. But what I wanted to mention is that Josh has really done some really good work around sensors. So you can see in this picture that this participant has got a sensor around her arm and also around her wrist, and these sensors allow us to measure, classify exercise, and he's got 3 exercises that he does, and he's able to accurately classify how many of the exercise each participant does. Also things like time under tension and speed of movement, etc., with the sensors. So this is really great step forward, and I guess in addition, and the next step on from the SEXY trial, trying to really ensure that we can measure accurately dose and what people have done. I did see Josh today, actually popped into the clinic and he did say that he is having a bit of trouble getting people to wear them and also do the tech side of things. So that is a bit of a shame, because it will impact on his data. However, it's a feasibility study. So part of the reason is to really look at how feasible it is to actually do these things. So just a take-home message, I guess, on dose before we move on. If you're looking at the literature, there's no strong evidence for a specific exercise dose. I want to make that point clearly, because I don't want to mislead you. I know that we have got 2 reviews showing preliminary evidence, but that certainly does need to be studied further before we can be really excited about it. But if you take a pragmatic view of the literature, generally if you do exercise for 12 weeks, you progress it with load, you have high volume, and you do it even every second day, it's probably the type of dose that is probably going to be effective. Having said that, the volume that people use in the literature is really quite ridiculous. So if we go back to this table here, they're doing upwards of 2,000 repetitions per week. So you're looking at a few hundred repetitions per day, which not many people do. So I think we've got to be practical as well. And I think you've got to be thinking about patient preferences and goals. You've got to be thinking about the biopsychosocial aspects, healthy understanding of pain, and a healthy environment to be loading. And also possibly one thing that might also influence your loading and your prescription is how much impairment they have in terms of functional impairment. So these things probably do allow you to temper this, because you're probably not going to give everyone yeah, preferences wise, not every patient's going to want to do exercise every day and do, you know, hundreds of repetitions. So we need to also keep the practical side of prescription in mind when we're thinking about optimal dose. So that was a bit on, I guess, dose. Let's move on now, and I just want to finish off with some pragmatic trials. So there have been some really incredible trials published in the rotator cuff tendinopathy space over the last couple of years. This is one of them. This is called a support trial from the group at Keele University and in the UK, and it's a pragmatic trial. So it was done in the NHS on fairly disabled people. So they had quite high severity and a very heterogeneous population. So you're getting people that are quite disabled, a lot of psychosocial, biopsychosocial factors. So what they do is a factorial RCT. So this is when you've got two factors and you're looking at the sort of the effect of each factor, but also the interaction. So one factor was ultrasound guided injection. So this is having an injection at baseline or not having an injection at baseline. And the other factor was physiotherapist-led exercise versus advice and exercise leaflet. So advice and exercise leaflet was pretty much an active control. So that is basically you get the leaflet and you work it out for yourself. And the other one was physiotherapist-led over multiple sessions. I think it was about 6 sessions. So that was their pragmatic trial, and they randomized 64 people per trial arm. So their findings, this is now findings from each of the factorials. There was from each of the factors, sorry, I should say. This is injection, where there was no effects whatsoever in the short or long term. They looked at 6 weeks, 6 months, and 12 months. And this is physiotherapist-led versus the active control pamphlet. And here there was a benefit for physiotherapist-led at 6 months only. So some an interesting finding, and I think supportive of an exercise approach, at least in the medium term. By 12 months, there were no differences, whether you have that active control, which is really interesting, whether you have active control. But there are certainly arguments to be made about getting people better faster, because they can go back to work. They can, improve their sort of psychological status. They get back to doing things they like. So there's certainly arguments that you can make from a cost, but also person-centered point of view, getting people back as soon as possible. I sort of felt a little bit sorry for these guys in the support trial, because then a few months after they published, the GRASP trial was published. And the GRASP trial is like nothing else that you've ever seen in the rotator cuff tendinopathy space. It recruited 800 people, which is just really a phenomenal achievement for a musculoskeletal trial. I think it's probably one of the biggest ever musculoskeletal trials. And they also had a factorial design. And this is also a pragmatic trial done in the UK, led by the group of researchers at Oxford University, who I think is led by Sally Lamb. So they recruited 700 people were randomized. 176 per trial arm, and their factors were again injection, so whether an injection at baseline made a difference, and they also their other factor was whether they all saw a physio in the other factor, but it was 1 session of physio versus 6. So that was the innovation, I guess, the difference with this trial versus the support trial. They were looking at not really an active control comparison, but a minimal intervention of 1 session comparison. I'll show you the findings in a second, but this is the exercise protocol. So they had 2 levels. The first level was really active assisted type exercises, and they've got some really good pictures and I'm pretty sure they've also published the education that they've done, which was really, really top-notch education with a lot of behaviour change to try and encourage people to actually do the intervention, and a lot of really good education. And then they went on to more resisted exercise, okay? And they looked at all the sort of elevation, rotation, all the common sort of movements that are done with rotator cuff tendinopathy. And then there's some optional, they had some optional resistance exercises, which were sort of a little bit more progressive, a little bit more through range or weight bearing that some people would progress to as well. So it was a good intervention, and they had some really interesting findings. So they found that there was a benefit for injection in the short term at 8 weeks. So if you had the injection of steroids, you had some benefit that you reported. It was small benefit. It probably wasn't clinically meaningful, but it was some benefit at 8 weeks. And that is compared to the other factor, which was the 1 versus 6 sessions, where there was no difference whatsoever. So that was really interesting. So basically what it's showing is that if you have people that you set up with one exercise, with one session with a physiotherapist, they'll probably do as well. And it seems like it at every time point as multiple sessions. And they did get better. They did report generally, some really substantial improvements in each group. So that has really challenged management in the UK, and I think that will lead to change in practice, particularly in the NHS. Now, we can't just take this evidence and apply it here. We have to then look at a trial to see if we're going to get the same effects here. And we're currently looking at trying to apply for some funding in collaboration with the group at Oxford University to try and actually replicate something like the GRASP trial here. So just to finish off, then I'm going to talk a little bit about an intervention that we've developed. So as part of developing this intervention, we've done a series of qualitative studies. So in these qualitative studies, we basically interviewed people who treat a lot of shoulder pain. This was the first one, and we asked them about what they think is really important to have in education for rotator cuff tendinopathy. And they said things like early focused education, really addressing beliefs. So people have inappropriate beliefs about exercise, about pain. That's a really important thing to address early on. And setting the scene, setting expectations, developing a really good therapeutic alliance and trust with the patient, make sure they've got really good buy-in. So these things really came out as quite strong themes. We then went on and interviewed patients about what they would like to see in education. And there was some really interesting and similar sort of themes that came up. One of the most interesting ones I thought was that patients really value anatomical education. They really, really love, and the surgeons do this really well, where they get the anatomy out and they focus on the anatomy. So that patients really do value that, and they want to know what's going on. They don't, and I guess that's a black and white thing, understanding exactly what the pathology is. They trusted health professionals and thought that they were the best people to deliver the education, and thought it should be individualized and very practical. So what could they do was really important to them. What could they do about their problem? Preferences for education delivery were quite varied though between people. So that was quite interesting. Then we've gone on to try and understand through a qualitative study again, what people's preferences are in terms of, what people's decision-making processes are in terms of having surgery. And this also uncovered some really interesting themes. And we interviewed here 18, I think it was actually 15 people who had rotator cuff surgery, either for tendon repair or plus or minus decompressions. And they pretty much had got to the point where they'd had it for so long, or it was so bad that they just wanted something done about it. And that was very easy to understand. They also had a very mechanical view, some of them. Some of them were sort of putting forward the view that I guess the simplistic view that, the overly simplistic view that if it's torn, it needs to be fixed, which we know is not necessarily the case for everybody. So, so that was interesting, and possibly an area where we can do better with education. They had real trust in health professionals. So they basically, you know, what the physio and particularly the surgeon said was really something that they valued. So that was interesting as well. So we've tried to come up with a bit of a conceptual model from that. I haven't talked about all the research that's led to this, but so this might not be as sort of flowing on from what I've talked about as it could be, but I call this the axis of evil, where you have imaging, people have imaging, not everyone, but some people get the wrong idea and the wrong meaning. And that's where our job as health professionals is so important in contextualizing findings on imaging, because patients, and we're just in the throes of finishing a qualitative study on imaging for rotator cuff, patients have clearly stated in that study that they don't care what the image report says. They just want to know what needs to be done and what the actual ramifications are. So so I don't think patients necessarily care that they've got a tear if we can contextualize it in the appropriate way. So I think failure of management clearly leads to surgery, and it should if the non-surgical treatment is good. But the problem is often non-surgical treatment is not good, and people have premature surgery or premature imaging. And I think surgery is absolutely crucial and necessary for the group of people who fail surgery or have got you know, exhausted other options. And I think it's our job as sort of I guess first line clinicians to try and make sure they're at that point by the time they go to surgery. Without necessarily, you know, without delaying surgery for the wrong reasons. So we're working on the STAR intervention, which I'm going to very briefly mention, and we're also working on education and a patient decision aid to help to try and address what I'm calling the axis of evil, where people get the wrong impression and slip down this, you know, premature surgery slope. Okay, so to address that problem, we've developed the STAR intervention. So the STAR intervention came from this pilot feasibility study, where we looked at 3 groups. We looked at an active control, we looked at online treatment, and we then looked at also the online treatment with tele-rehab. And we found that, and I should say that we did do tele-rehab for this trial, mainly not because of COVID. We started before COVID. We mainly did it because we wanted to reach as many people as possible, and we thought that was a good way of starting with tele-rehab. So we've got some preliminary data showing that it's a feasible intervention and that it probably does work. So now we've gone on and we were awarded a grant from HCF, which is to do a full-scale trial. So we're now undertaking this full-scale trial. So we've developed a really good intervention around that, and we've got a website where we basically have a education leaflet as well as exercise leaflet, and we're also trialing it at Complete Sports Care. So at Complete Sports Care, we basically have the intervention. So it does get a bit confusing because the intervention is called the STAR, which is shoulders tough and ready. And we've also got the trial where we're testing the STAR intervention, and the trial is called the ADVISE trial. So the trial is recruiting 333 people over 12 months, and we've recruited, I think, about 60 people so far. So we're about 20% of the way in. So at the moment, we are running the Shoulder Tough and Ready program, which, as I say, is probably similar to the GRASP intervention, but slightly adapted based on some of our findings, our qualitative findings. So that's basically all I wanted to go through. This is just a snapshot of part of the exercise intervention from the STAR program, where we sort of gauge intensity. But as I say, I haven't got enough time to go through it in detail today, but we do have a number of exercise progressions within the STAR intervention, and also some really good education. So to finish off with, just wanted to thank everybody who has been involved with the shoulder research that we've done, and all the PhD students and other research assistants, and also just other colleagues. So just to contribute, just to acknowledge their work. Thank you very much.
Thank you very much, Pete. Always a bit funny finishing a presentation in front of so many people and not getting a round of applause. So I'll give you a bit of a clap there. So yeah, thank you very much. I think there was some really good content, some really good questions, hopefully, that'll get raised as well. And yeah, just wanted to, again, raise everyone's awareness of the Q&A function. So we will have a good question and answer at the end. So yeah, definitely put your questions down and we'll pose it to the panel at the end. Pete may now have a little bit of time to even answer a couple just via text as we're going through Austin's presentation as well. But Pete, don't answer them all because we want a few for the end.
I was just going to say, Dave, I'm happy to go to flick through the PDF stuff that we've created at the end, if people are interested. The stuff that we use for STAR. I don't want to cut into Austin's time, so I didn't want to go through. I did plan to do that, but I don't want to do it now. We'll do it at the end if we have time. Okay.
Yeah, absolutely. Yeah, that sounds good. We'll see if we've got a bit of time at the end. But yeah, definitely write all of your questions up there as we go, and we'll pose them to the guys as well. So thank you again, Pete. I might get you to stop your share there just so Austin can put his presentation up. But Austin will be next. So again, I'll hand over to Austin.
All right, thanks, David, and thanks, Peter. Thoroughly enjoyed your talk. So firstly, I just want to thank the team at Complete Sports Care for inviting me to speak on a pretty important topic. You can see by the amount of attendees that the interest is generated. So look, what I'll spend the next sort of 40 to 45 minutes discussing is sort of my surgical perspective, and hopefully fits in with what Peter discussed as well. So as mentioned, I'm a shoulder and knee specialist. I've been specializing for 12 years, and in terms of shoulder pathology, rotator cuff is by far the most common condition that I see. So, so in terms of this talk, I guess to be a successful surgeon, you need to pick the right patients, and that comes really having a chat to your patients and examining them. So we'll talk about how I assess a patient who comes in with rotator cuff pathology and associated conditions. And as part of the assessment, what to look for in X-ray and MRI, why we choose these imaging modalities, and so how does it affect treatment. And then as Peter mentioned, surgery is definitely the last resort. So know when to pick patients for surgery. And then we'll discuss at the end latest management techniques, including some tried and trusted as well as novel techniques. And also importantly, what to do when you have rotator cuff pathology and tears that are not repairable. So I've got three sort of short case scenarios to highlight some important points. So we'll go straight into it. So we've got a very typical patient, 52-year-old carpenter, who has right shoulder pain for a couple of years. Worse after recent injury 3 months ago, lifting a ladder, and now has problems with overactivity and weakness. And as mentioned already, rotator cuff pathology can be a continuum. They can have impingement or bursitis. They can have a partial tear of the rotator cuff tendon. What do we do with those? If you leave them long enough, not all, but some can progress to a full thickness tear. And then if these tears are left long enough, they can reach the point where we describe these as massive tears. And massive is an orthopedic description that we use for tears that are larger than 5 centimeters or involve 2 or more of the 4 rotator cuff tendons. And these tears, if you leave them long enough, can become irreparable. So what do we do with those? Now, this term is also a bit of a mouthful, rotator cuff tear arthropathy. And all that really means is someone who's got glenohumeral joint osteoarthritis secondary to long-standing cuff disease. And just to highlight or illustrate how that develops, we know the rotator cuff tendons as a unit help rotate the arm and elevate the arm actively, but also as a tendon unit, they also help compress the humeral head onto the glenoid, keep it sort of centered. And if you have someone who's got long-standing cuff disease, and I'm sure you've seen these patients come into your clinic, when they move their arm up, they tend to hitch their shoulder up. So it's that constant sort of hitching of the shoulder, that rocking horse phenomenon of patients trying to contract their rotator cuff, but when they don't have rotator cuff, it's deltoid, that's sort of moving the shoulder up and down. That constant moving back and forth is what we call the rocking horse phenomenon, and that is what leads to arthritis in this setting. So that's how rotator cuff tear arthropathy develops, and it's becoming increasingly recognized in our community. In terms of presentation, rotator cuff pathologies, patients tend to present with shoulder pain, as mentioned, exacerbated overhead activity. They may give a history of trauma, but we know most of the time it's a chronic or degenerative condition. They usually present with weakness, and that the reason they present to you is they have reduced function. So that's why they come to you for your assistance. On examination, we start very basic. So look, feel, move. Nothing's changed from our time at university studying this. So inspecting for muscle wasting. Make sure you look for any wasting on the supra-infraspinalis fossa. And the shoulder is a good joint to actually palpate certain landmarks. So take your time to feel for any other potential pain generators. And Peter mentioned his talk. 70% of pain comes from rotator cuff and the shoulder. So where's the 30% come from? And so a lot of it does come from possible AC joint pathology or long-headed biceps. That tends to be the forgotten tendon in the shoulder. So particularly if they've got anterior shoulder pain, then you want to exclude any biceps pathology. And then it comes to movement. And generally with impingement or subacromial bursitis, they have this painful arc, mid-abduction, 60 to 120 degrees. And with someone who has a rotator cuff tear, they will have reduced range of motion, particularly actively. So for instance, you ask the patient to raise their arm up and they might actively get to 90 degrees, and then passively using the other hand, or you can assist them, they've almost got full range of motion. So that's different to someone who's got a frozen shoulder, who would have both reduced active and passive range of motion. So that's the hallmark of someone who's got cuff tear, reduced passive versus active movement. And then crepitus, I just put there at the end because, sometimes even without an X-ray, if someone has crepitus, you can almost diagnose someone who's got arthropathy underlying if they have that's clinical sign. So you've done your quick screening examination, look, feel, move, and now you can definitely hone in on your specific tests. And I call these special tests. So we all know Hawkins sign, looking for impingement, where you internally rotate and abduct the arm. In terms of testing rotator cuff strength, I like to test both arms at the same time. So we all know Job's tests and mid-abduction testing for supraspinatus. There's different ways you can test for subscapularis. We all know Gerber's lift-off test, where you ask the patient to put the hand behind their back and lift off. But I find that patients often find it difficult to get their hand far enough behind their back. So if they're starting from a low point, when they're trying to sort of elevate their arm, they're really testing triceps. So I prefer the belly press test. So ask the patient to put their hand on their tummy and forward elevate their elbow. And that indirectly tests for internal rotation in terms of subscapularis. And then testing external rotation strength, pretty straightforward. So you've done your screening examination. What do we look for on X-ray? And there's a lot of things we can look for. We can have assessment of the glenohumeral joint and the AC joint, as mentioned. And you want to also look for how well that humeral head is centered. Because as I discussed with you, if someone has long-standing and significant cuff pathology, that humeral head will tend to migrate upwards. And you can see this is a pretty extreme slide, but the humeral head's sitting quite high up. So you don't need an MRI to diagnose this patient here with that X-ray of having a massive, probably irreversible, irreparable cuff tear. That humeral head is pretty much sitting outside, abutting against the acromion. On the lateral view, you might see a large subacromial spur like this. Now, often get asked, how useful is an ultrasound? Ultrasound does provide you some information, but certainly if a patient comes to me and I'm trying to decide whether a rotator cuff tear is repairable, then I will rely on an MRI scan because it will tell us not just whether it's a partial or full thickness tear, it will tell us the amount of tendon retraction, but more importantly, the actual tendon quality. You know, how much that tendon is still good tissue or how much is it degenerate into fat, which is irreparable. So I'll give you a few examples. So this is a MRI of a right shoulder, and this patient has a partial, likely high-grade bursa-sided cuff tear. You can see the footprint here. There's still some cuff intact, but they do have a high-grade partial tear. This is a full-thickness tear that the rotator cuff tendons retracted maybe 1.5 centimeters. And if this patient ends up needing surgery after they've tried conservative treatment, then this is a tear that is potentially repairable in most surgeons' hands. Now, this is in direct contrast. You can see this is a right shoulder. You can see the rotator cuff tendon sitting well beyond the glenoid. So that tendon has retracted all the way from the greater tuberosity. So it's retracted, 4 or 5 centimeters. So it's going to be a big challenge if this patient needs surgery that you can be able to release the tendon enough to actually pull it down and reliably fix it back to the greater tuberosity. But this is probably the most important slide. So this is a T1 sagittal view, and you can see the scapular body here. Can you guys see the mouse? Yeah, perfect. So this is the scapular spine. So this is the front. This is the subscapularis. So you can see nice sort of muscle, which is black. This is infraspinatus and teres minor. And then have a look at supraspinatus sitting here in the supraspinatus fossa. So you immediately notice something's not quite right. And when you see more fat than muscle, generally that becomes irreparable. So you want to know before you get perform surgery that the patient has a rotator cuff that can be repairable. And there is a classification that came from the French surgeon. I spent a lot of time in France doing my subspecialty training. And it goes through 4 different stages, but generally stage 3 or 4, where you see the same amount of fat or more fat than muscle, that's generally irreparable rotator cuff tear. So Peter's already covered all of this, but I fully agree that in most of the time with rotator cuff pathology, even full thickness cuff tears, we always try conservative treatment first. And that involves, a cuff and scapular stabilizing program. We certainly give them analgesia. And sometimes you have to advise these patients to modify their activities, particularly if they're doing a physical type manual job. I do believe in cortisone injections, and I normally at least try 1 injection first, and that's done either in the rooms on ultrasound. And if you do send a patient for a cortisone injection, do ask them to keep a pain diary so that you do get that diagnostic benefit, because as you know, there's so many different pain generators in the shoulder, both within the shoulder and referred pain. And so for someone who has a cortisone injection, you want to know whether there's been any benefit, even if it's temporary. Because if the patient comes back and they can't remember how beneficial it is, you've lost that diagnostic benefit. And also, if they've had some limited benefit, then you might have to look elsewhere to see where the source of pain is coming from. So in terms of when does a patient need surgery, there's some absolute indications and then relatives. So absolute indications is someone who's got an acute rotator cuff tear, because I think acute cuff tears versus chronic tears is a probably completely different clinical entity. Chronic cuff tears are degenerative tears. They've torn over a period of time, and the shoulder's been able to compensate for this. And that's why we often see this in a clinical setting, where a patient comes to you with a very large chronic cuff tear, and you ask them to raise their arm, and they've still got excellent function. And that's completely different to someone who has an acute traumatic cuff tear, and so they haven't been able to compensate for that. So these tears don't do so well with conservative treatment. Likewise, tuberosity avulsion fractures. So these present essentially like a rotator cuff tear. But instead of the tendon tearing off the bone, they actually pull a bit of bone with them. And so if you don't fix these, then they will have ongoing weakness as well. Then there are relative indications. Potentially bursal-sided rotator cuff tears, larger tears, large to massive rotator cuff tears that potentially, if you leave them long enough, they can progress to become irreparable cuff tears. And I think subscapularis tears, because it's such an important function, there's not many internal rotators in the shoulder. So large subscapularis tears, I do have a lower threshold for recommending surgery for. And as mentioned, any chronic cuff tear that has failed conservative treatment, and there's no rule in terms of time frame, but 3 to 6 months of conservative treatment, it sounds about right to me. So what do we do once we decide that a patient needs a rotator cuff repair? So basically, this is a typical sort of crescentic type tear. We pass anchors into the bone and pass sutures arthroscopically. Some surgeons still do it open and then repair it down. I'll just show you a short slide in terms of how we assess the rotator cuff. So intraoperatively, we make sure that we've got a good bite of the tendon, make sure it's mobile and repairable. We debride the footprint, pass these anchors into the bone, which has sutures attached to it, and use these arthroscopic instruments to pass the sutures. And generally for larger tears, we tend to do a double row repair. So that means anchors laterally and medially, and that sort of compresses the whole footprint back on the greater tuberosity. And certainly at day 0, that repair isn't strong enough for them to go back doing any physical activity. All we do is get the tendon back to the bone, and hopefully their healing response and healing process takes time. And this is the key thing in terms of, Peter mentioned, patient education and expectations. You do have to warn patients it's a long recovery. It's not a quick fix. So it's a 6-month rehab program at least. So they generally, this is fairly standard. I'm pretty sure amongst most surgeons, we send them in the home in a sling for about 6 weeks. They can start doing some gentle pendular and passive range of motion up to a certain range. At 6 weeks, we let them come out of the sling completely and progress to gradual full range of motion. And we don't really load that repair until about 3 months with some light strengthening. And hopefully at 6 months, they've made a good recovery. So you do have to warn patients that it's a 6-month process. So moving on to the second case, and this is a very typical scenario. The reason I highlight this is that 1 or 2 of these gets missed every year that I see, particularly in the emergency department. So we have a 74-year-old lady who trips over and dislocates her shoulder and presents to the local emergency department. They reduce the shoulder. They do an X-ray and there's no fracture and the shoulder's reduced. And at that stage, it's very easy just to send the patient off and without any further follow-up, thinking that the shoulder's been treated correctly. But we know down the track, and this is what this sports physician picked up, that patient has ongoing pain and weakness, can't lift their arm up, and essentially no rotator cuff function. And they present with what condition we call pseudoparalysis. That's the inability to actively elevate the arm beyond 90 degrees. So as I mentioned to you, the absolute indications for surgery is an acute rotator cuff tear. And you may only see this 1 out of your 20 patients with cuff pathology, but you don't want to miss them. And that scenario I just described is very typical. So someone who dislocates a shoulder, so it's a definite traumatic event, and it takes a lot of force to dislocate a shoulder. And we know based on studies that over 50% of people over the age of 50 with the dislocated shoulder have acute rotator cuff tear. So this is different to a young patient, athletic patient who dislocates their shoulder on the footy field. Their rotator cuff tendons are more pliable and able to withstand those forces. But if you're at the age of 50 with potentially degenerative cuff already, most of them will have a cuff tear if you don't pick it up at the time. And they present with this scenario that I showed you, this massive, large retracted rotator cuff tear, which becomes irreparable. So what are the treatment options for massive irreparable cuff tears? In the past, we didn't have any options. We used to put a scope in the shoulder, maybe do a partial repair, maybe address their biceps or AC joint, and that might relieve some of their pain, but reliably, it wouldn't improve their function significantly. We used to talk about tendon transfers, although this is becoming a bit of a dying art. There's less and less surgeons doing this, and even those surgeons still do these. The numbers are reducing because we have other options now. And this includes this technique, which I'll describe briefly, which is a superior capsular reconstruction, which has only been around for the last few years and only has very specific indications. And then last but not least, reverse shoulder arthroplasty. This has been, Peter's talked about game changer in his title for his talk. This has been a game changer for us as orthopedic surgeons in terms of being able to treat someone who's got irreparable cuff tear. And if, as I mentioned, if you leave these irreparable cuff tears long enough, they develop cuff tear arthropathy. So, arthritis as well as rotator cuff tear. And they're the ideal candidates for reverse shoulder arthroplasty. So I'll talk to you briefly about superior capsular reconstruction. My disclaimer is I've only done one of these. It's a fairly new technique, and the evidence is certainly still evolving. But this basically developed in Japan at a time when reverse shoulder arthroplasties were not allowed to be done at that time. Now it's been approved, but it was at a time when they didn't have the option. So they had to think outside the box. And their aim was to restore that superior humeral stability. That X-ray I showed you where that humeral head's sitting high. So by reconstructing the capsule, by keeping the humeral head centered, hopefully they can improve their range of motion. And Mahara was the pioneer of this technique, and his results were impressive, and in all honesty, have not been able to be reproduced by many surgeons around the world. So I take that with a bit of grain of salt, but yeah. The indications, though, are young patients with symptomatic large and massive irreparable cuff tears. And the reason I say young patients is that these patients are too young to have a reverse shoulder arthroplasty. Joint replacements in general, where you're talking about hips, knees, shoulders, we don't tend to do these in patients under the age of 50 because we know that they will wear it out in their lifetime. So we're trying to look for other options. So this is the indication for it. They need intact subscapularis and functioning deltoid, and they need to have minimal glenohumeral arthritis. So very sort of specific indications. And the techniques have improved. So basically, anyone who can do arthroscopic rotator cuff tear can potentially learn how to do this technique. And it's using the same sort of anchors, but instead of repairing the rotator cuff, we use a allograft, and one of the common ones we use is a quads tendon allograft, which provides a nice thick tendon. And by restoring that capsule at the top, you stop that humeral migration, so hopefully be able to restore some function, allow the deltoid rather than hitch the shoulder up to elevate their arm. But by far, the gold standard for irreparable rotator cuff tear is still a reverse shoulder arthroplasty. So for those of you who don't know much about reverse, it's a technique that came out of France about 40 years ago, but becoming particularly popular around the world 20 years ago. And the concept is very simple. So on the left, you have what we call a standard anatomic shoulder replacement. So, replacing the ball with the ball and the socket with the socket. And then reverse is basically just flipping that whole construct around. So you can see on the right hand here, you've got the ball, which we call the glenosphere, on the socket side, and then the socket on the humeral side. And how that works is by putting the ball on the socket side, you effectively medialize the center of rotation. So you can see by the arrows there, it's almost double how far you medialize the center of rotation. And what that does is now, because you've got no rotator cuff, and remember that earlier slide I showed you where you get that rocking horse phenomenon of the deltoid hitching the shoulder up every time you try to contract the shoulder. So now by medializing the center of rotation, you allow deltoid to function more effectively by lengthening the lever arm of deltoid. So instead of deltoid hitching the shoulder up, it now effectively becomes a rotator cuff and elevates the arm. So just in very simplistic terms, by putting in a shoulder replacement, you're now allowing deltoid to function like a rotator cuff by changing the biomechanics of the shoulder. And just to illustrate how far that center rotation is medialized. And sort of biomechanically, it makes sense. You know, by having a longer lever arm, you need less strength to lift your arm up. And and this construct now allows deltoid to work more effectively to elevate the arm. So, now indications for reverse shoulder arthroplasty. So this slide is important because there is a limit. You never promise a patient you can lift, you know, they're going to have their arm back to normal. But if you can get someone who's got pseudoparalysis, so inability to elevate their arm above their shoulder, to now get their arm above their shoulder, say to 120, 130 degrees, that really restores a lot of their activities of daily function. They can now get their hand and elbow to space and do a lot of the ADLs. So I'm just going to pause here for a second, just to charge, put the charger on the laptop before I run out of battery. Excuse me. All right, so we're good to go again. So indication of reverse shoulder. So this is, you really have to get your head around this. So it's definitely indicated for someone who's got arthritis, you know, cuff tendinopathy, as I mentioned, but also we're doing for patients who absolutely have no arthritis in the shoulder. So in terms of patient education, it does take a while to sit down with the patient, explain this to them that we're doing a shoulder replacement, not for arthritis, but to actually improve your function by being able to elevate their arm without a functioning rotator cuff. So without arthritis. We also do in the trauma setting, so 4-part proximal humeral fractures. And we also do a post-traumatic arthritis. And also rheumatoid arthritis, we have poor cuff tissue. And this is an Australian joint registry, which you may not be aware, but every operation gets done in Australia, gets logged. And so we have the best registry in the world because we collect a lot of data. And you can see here, since 2011, the yellow graph is reverse shoulder. It's bypassed total shoulder in terms of usage to the point now where it's certainly more than double. You know, we're doing more reverses in patients because we know it works. And these aren't small numbers. We're talking about 36,000 in Australia since 2004, most of the age of 65. And in terms of survival rate, and this is in terms of time it takes to revise a joint replacement, you know, 94% are still working quite well at 10 years. And the data is still being collected on this. So this is a typical patient.
6 weeks of surgery. This is what I had to do before the surgery to get my arm here. Now I can do this.
So one of the main limitations reverse, they have very good elevation, but because it's well a constrained joint, you do have to warn patients that rotation, particularly internal rotation, is limited. So particularly for women, they will find it hard to get their hand behind the back to do their bra. So it's something that you need to educate the patients about. So we'll move on to the last case. So this is a 62-year-old male truck driver who has anterior shoulder pain for a few months, lifting a heavy load onto the back of his truck, and now feels a pop in his arm, has bruising down his arm. And he presents with this. And I'm sure you've seen this. We call this the Popeye sign. The clinical diagnosis is a long-headed biceps rupture. You don't need a scan for this, but you know, often patients end up having a scan, and you normally see an empty biceps groove, so there's no biceps there. Now, the reason I brought we're discussing biceps because there is a relationship with biceps ruptures with rotator cuff tendons, but acute biceps ruptures by themselves don't need any surgical treatment. The reason being is that you still got the short head attached. They still have excellent function with their biceps. The only thing that they notice is that cosmetic deformity, which is the Popeye sign. But biceps pathology as I mentioned to you, is a important pain generator. It's often forgotten tendon. So you want to, as part of your assessment, see whether there's any pain coming from the biceps. And that could be either from a biceps rupture, like that acute tear. It could even be just tendinopathy of the biceps, or even subluxation. So the biceps can subluxate out of the groove and cause pathology. And so the important thing to notice is, particularly if you ever get a patient with an ultrasound MRI finding of a biceps that's subluxating out of their groove, then more often than not, that's associated with subscapularis tear. You know, for that biceps to pop out of the groove, it must go through the medial pulley, which subscapularis forms part of that pulley. And so you want to be able to pick up a patient who has subscapularis tear. Now, biceps pathology by itself can be treated surgically through two ways. It's either tenotomy or tenodesis. And tenotomy is simply releasing the tendon and letting it drop. So, you know, a surgeon essentially creating a acute biceps rupture. And that stops a lot of the pain generating from inside the shoulder by letting the biceps drop out of the groove. If they're worried about cosmetic deformity or a Popeye sign, then we often do a biceps tenodesis, which means reattaching the biceps further down the arm. So for instance, this patient on the left, he will be concerned about his Popeye sign. So in these patients, we often do a biceps tenodesis, whereas this lady, I don't think she will notice whether she has a Popeye sign or not. So a tenotomy in her will work quite effectively as well in terms of reducing the pain from a biceps pathology. So in summary, in terms of rotator cuff tears, non-of treatment is initially instituted unless they have acute tears. I often use MRI to assess if a cuff can be repaired if they need surgery. You now understand that reverse shoulder replacement is an option for patients with irreparable cuff tears, and definitely don't forget about other pain generators in the shoulder, including the AC joint and long-headed biceps. All right, so thanks everyone for your attention.
Thanks very much, Austin. That's brilliant, and gotta love you know, the old live webinar function. Losing the battery power on the computer, that's great. But we didn't lose you, which is good. Okay, so we do have quite a few questions posed, which is great. So I think that'll give us a bit of discussion now. So what we might do is I might sort of bounce between Steph and myself just to pose a few questions to either Pete or Austin or both. So I might let you start off, Steph, if you like. So we'll filter through as you go and cross them off.
Beautiful. I'll scroll up in the chat here. So I can see someone's asked, why is manual therapy even an option, not an option in research anymore? Pete, that's probably a question for you. So why is manual therapy not even an option in the research currently?
Look, they do still do manual therapy. So for example, the review, the big Cochrane review that I talked about there, they looked at exercise and manual therapy, because I think if you look back historically, the things that we used to do for tendinopathy were exercise and manual therapy. Possibly related to that Cochrane review, there's been a bit of reduction in use of manual therapy because the findings weren't very positive for manual therapy from that Cochrane review. So that's possibly one reason. But even in things like the GRASP trial that was published in the Lancet last year, there was manual therapy, but that was down to the discretion of the treating physiotherapist in the group that had 6 sessions. So in the arm that had 6 sessions, the treating physiotherapist could choose to do manual therapy or whatever else they wanted to do. So there still is manual therapy within these trials, but what we're finding, and this is the GRASP trial and some of these other trials, is that maybe it's not necessary. it doesn't seem to lead to the benefits in the short term or in the long term when you include it. So yes, manual therapy is, it does lead to benefits. It might lead to short-term benefits. It makes people feel better. We know that. But over the long term, when we look at it in trials, it doesn't seem to have an effect over and above not doing it. And I think that's probably come across with the literature, so people have not done it. Now, a lot of physios will probably be up in arms thinking it's really important. You need to do manual therapy to get people going. And it probably does help to develop a working alliance. I think the way I think about manual therapy is it does develop working alliance and it develops the bond with your patient. So that's probably one of the best reasons I can think of to do manual therapy. So it probably does have a place. Yeah.
And just a brief follow-up to that one as well, similarly in the research, why are there not measures for shorter than 6 weeks post-intervention? Example, 72 hours to 2 weeks.
Well, it really does depend on the intervention. So whenever you're designing a trial, you tend to have outcomes that are going to match what effects you're going to have, when you're going to see the effects. So for example, with surgery, you've got to have long-term outcomes because we know that it's going to take a long time to sort of recover. With exercise, you tend to have 12 weeks, but maybe that's not enough for a lot of the effects that we want to see. With manual therapy, they have short-term outcomes. So a lot of manual therapy studies that you look at, they sometimes do crossover designs where they have outcomes of a week or something like that, or even a few days or even immediate. So they sometimes do. It really does depend on the intervention.
Great. I'll turn the next one to you, Dave.
Perfect. I might throw one to you, Austin. So I've got, in your experience, what percentage of patients will benefit from a cortisone injection? And just additional to that as well, do you have any information about which patients may respond best to a cortisone injection?
Thanks for that question. Look, very, very hard to answer. As we discussed, there's so many different pain generators. But if you think a lot of their pain's coming from, the bursa or cuff pathology or cuff tendinopathy, then I think anecdotally, more than 50% will respond. So yeah, I'd try at least a cortisone injection to see whether that helps or not.
Yeah, so hard to work out which patients may benefit. Again, additional to that, do you have any, I suppose, specific tests or ways which you might differentiate whether someone has like bursal pain versus cuff pain versus biceps pain?
Yeah, absolutely. So look, there's different tests you can do for biceps, and I think that's something that I really want to stress, that the biceps pathology, a lot of trainees that I teach, they still forget about that. So there's different tests you can do for biceps. There's Speeds and Jurgensen's test, but for me, direct palpation. And so the best way to palpate, and look, it's an easy landmark. You can feel it on everyone's shoulder. So if you internally rotate around 15 degrees, you can sort of feel you can feel directly anterior to the shoulder, your biceps sitting right there in front of you in the groove. And so compare to the other side, and you need to compare the other side, because if you push hard enough, I'm sure if I push hard enough on your shoulder, David, you'll yell out as well. So yeah, just compare each side, and that's probably the best clinical sign for biceps. Apart from the history, anterior shoulder pain, I think someone posed a Q&A about anterior shoulder pain. So you got to think biceps pathology straight away with that. In terms of other clinical signs, Hawkins sign I use for, impingement, subacromial bursitis, and probably those patients probably tend to do better with the cortisone injection. So they've got clear impingement signs as well as painful arc. And rotator cuff, the hallmark is reduce, in terms of rotator cuff tear, it's reduced active versus passive movement. And so I think that's a good differentiator compared to, as I mentioned, frozen shoulder, other pathologies.
Brilliant. Steph?
Okay, just working through the chat here. This might be a question for both. What are the deciding factors for failure of rehab and going ahead with surgery? Peter or Austin probably answer that one.
I can go quickly from a rehab perspective and then throw to Austin for reasons to have surgery. I think from our research, we've done a few surveys and tried to explore people's sort of perspective, patients' perspective about why they then go on to have surgery or what sort of has maybe not worked. A lot of the time it comes down to the rehab not sort of working for them because they've been in too much pain or they haven't been able to implement it properly or do it enough. So there's issues with the exercise itself and not doing it. Some people are just in so much pain that they just can't do the exercise and they just cannot, get a foothold with the exercise. And maybe they're the people that, maybe the steroid or other interventions for pain. So it comes down, I think, largely from what we've learned from the work we've done. It does seem to be around people not being able to progress with the rehabilitation, but it could also be a lot of other, and Austin mentioned this, expectations. So a lot of times people will think, oh, maybe I do need surgery because I've got a tear, and that expectation can set them up for failure with conservative care or non-surgical care because they are always thinking in the back of their mind they need surgery. So that education around addressing expectations and beliefs, I think, is very, very important. But that's sort of, I guess, some of the main reasons. But as I mentioned earlier, it's also really important to recognise when people have done good exercise, they should then be referred on to get an opinion. But I'll let Austin answer the question about maybe the sort of, indications for surgery.
Yeah, look, you've touched upon this as well, Peter. It's probably the quality of the physio, varies so amongst different practitioners. So understanding that the patients have the right quality of the rehab. And as you mentioned, in terms of pain, yes, some patients, doesn't matter how good the physio is, if they're in so much pain, they just can't do it. And so that's where cortisone, and I normally always try cortisone as well as physio hand in hand, just to allow them to hopefully, break through that pain barrier so they can push through it and give the physio a best shot at it. But yeah, so that's how I treat them.
And Austin, just in addition to that, you mentioned cortisone. You also mentioned analgesia in your presentation. Is there any specific analgesia that you'd recommend to these kind of patients?
Oh yeah, generally just over-the-counter stuff, Steph. So Panadol or Panadol Osteo or some anti-inflammatories. But definitely, if you're going to prescribe anti-inflammatories, just a short course, because obviously the side effects with kidney problems and stomach ulcers. So yeah, just anything you can do to try break through that pain barrier, so they can, do their rehab more effectively, and hopefully not require surgery.
Perfect. Thanks. Dave, next one.
I think this is a bit more for Pete. So how much do you believe that posture or poor posture might contribute to rotator cuff tendinopathy? And do you have any emphasis on correcting this in your rehab programs personally? You're just on, mute there, Pete.
Sorry, the most common phrase on Zoom, you're on mute. If you look at the evidence, it's a bit mixed for posture. So the relationship between posture and rotator cuff symptoms, or a lot of conditions, is a bit mixed. So there's no clear link in the evidence. So I think it's probably an individual approach. So for some people, you probably would look at posture and maybe, implement some modifications. One of the ways you could do it is via a symptom modification type approach. So if you're modifying their posture and their symptoms are improving, possibly that's an indication that, looking at posture is going to be helpful for that individual. So I think an individual approach where you can sort of test the effect of posture via symptom modification is probably the way that I would go. I think it's useful to try and find positions where they can do the exercise a bit more easily with less pain. And that might improve modifications of posture. So what the effects are is unclear. It's interesting because symptom modification was introduced by Jeremy Lewis, and it's actually quite popular, and it is quite a good way of sort of thinking about how you can improve exercise for people. And basically it just involves things like changing posture. It might be even just a simple thing like an elevation of the scapula or retraction, or something like that, external rotation of the arms, some loading, and people can feel better. But Adam Meekins has his one and only study contribution to the scientific literature was I think he swore never to do research again after that, but he's obviously a very vocal clinician on Twitter. He did a study looking at the reliability of the symptom modification maneuvers, and it wasn't very reliable, he found. So it's interesting, but it does seem to be beneficial for some people, I think.
Thanks, Pete. Steph?
Austin, I have a question for you in the chat here. If an MRI presents with a rotator cuff tear with retraction that is clinically symptomatic, who hasn't trialed conservative management, is it still worth trying if there's a chance that the tendon could be irreparable if conservative management fails?
Run by me again.
So it's a question posed by Joanne at 8:06 p.m. if you want to read it yourself. If an MRI presents with a rotator cuff tear with retraction that's clinically symptomatic who hasn't trialed conservative management, is it still worth trying if there's a chance that the tendon could be irreparable if the conservative management fails?
Yeah, so I think in short answer, yes, there is a role for conservative treatment as long as it's not an acute cuff tear. So remember we spoke about the difference between chronic and acute tears. So chronic tears, potentially you can still have good function. And so I think there is a role for conservative treatment, but if you've got an acute cuff tear, then I would critically analyze that MRI scan, look at not just the amount of retraction, but also the amount of fatty atrophy. Hopefully at that stage, if it's an acute cuff, to recommend surgery before that atrophy becomes irreversible.
Great, thank you, Austin.
Pete, one for you. So what are the key education components addressed in the GRASP and STAR trials? So how is it delivered? And is that like a lecture or physical handouts or one-on-one?
Yeah, so look, it's a bit, thank you for the question. It's a good one. Gives me an opportunity to share my screen and show you, because this is what I was going to allude to before. This is our education. I don't know if, can people see that or not?
Yeah.
No, you can. Okay, so this is our education, which is it's basically adapted from the GRASP trial. We have got, I know one of the co-authors on the GRASP trial is a long-term collaborator. I was one of his PhD external examiners, and he's gone on to do a lot of good shoulder research. So he has, we've sort of talked with the GRASP trial people before we developed our stuff, and have based a lot of it, well, not a lot of it, but have certainly informed our intervention based on theirs. So it basically goes through anatomy, it goes through pathology, it goes through the types of signs and symptoms. Do people need a scan? It goes through the risk factors. It goes through treatments. So the types of treatments that people need. It goes through the benefits and harms of every treatment, which I think is really important for people to then make informed decisions about what they want to do. It goes through pain and what is acceptable pain, and just the concept that some pain is acceptable during movement and exercise. It goes through activity modifications that they can do, which seem really, really basic. Sometimes you're talking to patients about these and they're like, you're teaching me how to suck eggs, basically. But it sort of brings up some interesting stuff from patients, and you try and get engagement. So generally, we're presenting this in a group format with 3 people, and we generally would try and engage people to ask them about their experiences of scans, their experiences of diagnosis, their experiences of modifications, etc. And then it goes through just basic advice about some pain medications and how to treat pain. And there's a lot in there, but it's basically all around, I guess, beliefs and around some of the sort of pathology and pain relationships as well. The other thing that we have as part of the grasp is the exercise. So we've got 5 exercise movements: elevation, external rotation, push, pull, and press. And within each of those movements, it's sort of progressive. So within each of those movements, you progress to sort of harder levels. So it's really just a very functional exercise approach, which again is based on grasp and some of the prior trials. So this is just the exercise log and the progression. There's a fair bit of behaviour change in the grasp trial, and we've taken a lot of that into our trials as well. So people do an action planner, they try and sort of set aside times when they're going to do the exercise, they try and set goals, and so it's really trying to get them to really engage with the rehab process a lot as well, which is really important. So yeah, so that basically is a bit of a snapshot of what we do in the ADVISE trial. But as I say, we're testing this as a tele rehab now, and we're testing this as tele rehab, but we're also testing it as face-to-face. And the face-to-face trial is going to start this year. So we've got 2 trials running, the full-scale tele trial, and then the face-to-face trial, which will start this year. The reason we went tele is because the initial approach was meant to be really trying to get education to the masses, and we thought telehealth was going to be a good way of doing that. We also had an online-only intervention in the original trial, because we thought that could be really good for just educating people in a passive way without the need for a therapist. But we found out that people don't like that. They actually want someone to deliver the education. We found that out from our qualitative work, but also the response to the online-only intervention. So people don't trust the advice unless, even if it's good advice in a nice format, they don't trust it until someone who's a professional tells them that it applies to them, basically, which we thought was interesting. So we've gone away from the online-only interventions to more a minimal intervention of just the one session versus the multiple sessions, which is what we're looking at now.
Brilliant. Steph, you're on mute as well.
Of course, that was good form by me. Austin, I just have a question about sort of that window for acute rotator cuff tears. Is there a crucial sort of time period where intervention really needs to be applied to prevent longer term outcomes when you're dealing with an acute injury?
Yeah, look, once again, there's no hard and fast rule, but generally the earlier, so within 6 to 8 weeks, I think the tear's fresh enough where you can still mobilize it. They haven't undergone the phenomenon that we discussed, sort of fat atrophy. So it's sort of 6 to 8 weeks. If they go beyond maybe 3 months, that's when they potentially become irreparable. And that's, I think, this what happened to that case number 2. Yeah.
Perfect, thank you.
Pete, is there any efficacy for shockwave in rotator cuff tendinopathy? Mute.
Shockwave is interesting. It is not really. It's one of those adjuncts where the efficacy is quite uncertain still. So if you compare it to interventions like doing nothing at all or exercise, it often comes out as better, or at least as good as exercise. But if you compare it to interventions like placebo control, it comes out as mixed, i.e. sometimes it's better than placebo, sometimes it's the same as placebo, i.e. placebo is the only mechanism. So it's really mixed, and we're doing a trial at the moment looking at shockwave versus placebo for insertional, which you and Steph are very well aware of because you're influencing it, and it's that will be interesting because we still don't know whether it's different to placebo. And I think I think for interventions where there's a bit of cost or a bit of harm, we need to know about placebo control. You can argue you can do placebos, like maybe manual therapy, we talked about that earlier. Maybe partly that is, well, everything has a slight placebo element to it, or a small or large placebo element, but you can argue that things that are harmless and very cheap, placebo is not an issue. But where there's potential, where there's cost involved, like Shockwave, people charge a lot of money for it. So you generally want to know whether these things we should be investing money into. So I do use a lot of Shockwave, but I would definitely stop using it if I found it, if there was certainty about the placebo control answer, which we just don't have at the moment.
Pete, another question for you. The question is, how does the pathology, example tendinopathy versus rotator cuff tear, change your rehab journey, or maybe should, or how does it change basically?
It doesn't really change at all. So if you think about rotator cuff related shoulder pain or rotator cuff tendinopathy, because it is a clinical diagnosis that is basically blind to pathology, you don't need pathology to treat it. Sorry, you don't need imaging to treat it. It really does ignore it. So it doesn't, and that's not to say pathology is not important. It might be very important for that individual to go on to have surgery or a bursal injection or whatever it is. But in the first line treatment, we just treat based on those signs and symptoms that are present, that are consistent with that condition. So it doesn't matter. It actually doesn't matter at all. And you just treat whatever impairments are there. So it could be pain with elevation, or it could be, restriction of movement for some people. And you basically just are treating the impairments that are there. So I don't think it actually matters. And even if you did have the imaging, if you were having, say, people come in with an image already, again, it probably doesn't matter. You still treat the impairments and the movements and the function. So that's probably the approach, which is similar to Achilles, which is the other thing that I see a lot of. It's regardless of whether there's bursa or other things there, it's still the actual rehab approach is still the same.
Lovely, thank you.
Thanks, Pete. This one's potentially to both of you. This one's a bit to do with the specificity of some physical tests. So the question was specifically posed around the Hawkins-Kennedy test. So the question asker suggests that they felt that a lot of those tests are being disputed a little bit in which structures or tissues are contributing. So whether they have that specificity of structure when we're doing the test. So do they direct treatment a little bit, or are they more just we're finding out that something that we know that the person has shoulder pain, essentially?
Yeah, look, I can answer that as well. So look, I think most of any clinical test, and we all know this, it's basically just to hopefully confirm what you know already based on the history. I think most of the diagnosis can be made from a history. They say 70-80% of the time. And so whichever test you rely on, there's no perfect tests. I think it's important just to pick one or two for each pathology, get used to it, and then during your career, you sort of work out, how effective it is in your practice. So that is a useful test for impingement, but is it 100% specific and sensitive? Definitely not. And that's where a cortisone injection can add to that weight with a positive result. And similarly with, AC joint, there's probably 50 different tests for AC joint pathology. And so, and for me, still the best test is direct palpation, and same with the biceps. So yeah, I think that the take-home message is just pick one or two tests that you can reproduce and stick to that.
Do you have anything to add, Pete?
No, I think that's covered it nicely.
Mm-hmm. Excellent.
Yep.
Steph?
I've got a nice question from the chat, and probably for both you and both you, Pete and Austin. So you talked about how patients value being educated about their condition/anatomy, etc. Keen to hear how you describe what a rotator cuff tendinopathy is to a patient, or how you educate them around what their condition is.
Do you want to jump in, Austin, or do you want me to start?
Yeah, you can definitely start.
Yeah, I basically would, I guess, start off with when I'm educating people, start off with how they've got it, like some of the risk factors and load and some of those other risk factors we talked about, and then talk about the pathology, talk about the pathology-pain relationship, or not a clear relationship, reassure them about pain with movement. That's sort of the approach that I generally take, but I try and use the education stuff that I've got there. I think the other thing that's important is to educate them about the treatments that are available. And I think physios don't do that as well as what we could. And we found this with our research and surveys as well. Physios tend to focus on physio treatments, which is, probably fair enough because that's what we know. But I think surgeons do this a bit better, where they say, look, there's exercise, there's injections, and there's surgery. And I think we should be laying out the treatment options and the positives and the negatives of each one in a way that probably early on, so people are aware of things. So I think that's important. The other thing that's really important with education is getting clarity with terms, because people will go to all these different clinicians and they'll hear all these different terms. So they'll hear bursitis, impingements, rotator cuff disease, tendinopathy, tears. And I think if you can just reassure them that you're dealing with probably similar signs and symptoms with maybe some slight differences, but that's reassuring to people, because then they won't go to the surgeon and the surgeon says, oh, you've actually got this. And they think, that physio didn't know what they were talking about. He said, I've got this, and now the surgeon's saying this. So it covers you if you can then describe all the pathology. And I think surgeons, I'll hand over to Austin, because I think the thing that probably surgeons do well is that sort of pathology side of things and going through that.
Yeah, spot on. Look, Peter, most patients come to you with these terms already before they even speak to the clinician. They come up with an ultrasound scan or MRI result, and they've highlighted all these things. I've got a partial tear, I've got bursitis, and it seems quite scary to them. So, like you said, it's our job to put perspective on it and reassure them. And look, I just start, whether it's cuff tendinopathy or rotator cuff tear, explain this is a very common condition. So, and then sort of put in perspective, we know over the age of 50, a lot of them will have a partial tear or full thickness tear and don't even know about it. So once patients hear that, then they're sort of more open in terms of all the treatment options that you talk to them about in terms of non-surgical and surgical. So that's where I start, just giving patients perspective.
Brilliant.
Lovely.
I reckon we may look at wrapping it up there. I reckon we've done pretty well getting through most of those questions tonight. We're coming in close to that 9 o'clock mark, which is great. So thank you very much both to Pete and Austin this evening. I think we can all agree some really great information there, and some really good some information on some of the most recent trials as well, which is great to have summarised. If you all have benefited from a lot of this this evening, I know Pete is about to run his lower limb tendinopathy course. I think some dates in both Melbourne and Darwin over the next few months. Yeah, jump online. I will actually send around an email to everyone tomorrow, which will have a link in there. So you're very welcome to have a look at that course if you are either in Melbourne or Darwin. Obviously some really good quality information there if you really want to up your game in managing lower limb tendinopathy. So again, thank you all for joining. We will probably run a few more of these over the course of this year and next. So keep your ears to the ground on the various topics that we might be presenting on. But thanks again for joining us, and we will hopefully see you all again next time.